The first question for today is which of the following renal stones are radiolucent? And your options are triple phosphate stones, uric acid stones, cysteine stones, or calcium oxalate stones. So the question is which of the following renal stones are radiolucent? And your options are triple phosphate stones, uric acid stones, cysteine stones, and calcium oxalate stones. So welcome everybody. Welcome to this 13th session of MCQ Live by Medico Apps. I am your Dr. Abhishek, your mentor of MCQ Live sessions at Medico Apps. And these live sessions are basically, to help you know high yield topics, to help you practice previous year questions on high yield topics, so that not only you learn the concepts but you are able to actually use the concepts, for exam. Okay, so this is a series every week around 3 to 4 sessions I take in the evening 4:30 5 o'clock, based on my schedule. And today is the 13th session. Again, tomorrow we have got the 14th session again at 4:30. So if you are new to this session, make sure that you subscribe and hit the bell icon so that whenever I go live, whenever there is a Medico Apps live session, you get notified. And I would really love if you can give a thumbs up and share this video. If you have any follow-up question on this particular topic, or if you want to give any suggestion to, how to improve these sessions, please put in a comment, because then I will read it, I will reply to you, and I'll make sure that I, kind of use those feedback to improve these sessions. So this was the first question. Which of the following renal stones are radiolucent? Now remember, 80%, 80% of the renal stones are radio opaque. Okay, and only 20% are radiolucent. Okay, which means when you do an X-ray, you will not be able to see these stones on X-ray. Now, this is very important, because whenever an examiner asks you a question, what is the investigation of choice for a suspected case of renal stones? Don't answer X-ray KUB. This is not the correct answer, because if you answer X-ray KUB, you are going to miss 20% of your stone cases. Is this clear? So, what will be the investigation of choice? I'm coming to what are the radio lucent A. What is the investigation of choice? Investigation of choice will be non-contrast CT of abdomen. Why am I saying non-contrast? Because sometimes these patients may have borderline, renal functions, and if you use contrast, you may precipitate the, renal injury, okay, or renal functions. You may compromise the renal function. So non-contrast CT abdomen becomes the investigation of choice for these patients. So whenever we are talking about radiolucent stones, remember the code word LUX. So what is L? L stands for lucent, which will help you to remember that we are talking about radiolucent stones. U stands for uric acid, and X stands for xanthine. Okay? So xanthine and uric acid, these are the only two stones which are radiolucent. Rest all the stones are radio opaque. Look, triple phosphate stones will have calcium, magnesium, ammonium phosphate, right? So whenever there is a calcium, you will have, a radio opaque stone. Similarly, cysteine are very hard stones, okay, very hard stones. So again, they will be radio opaque. Calcium oxalate, calcium is there, so radio opaque. The correct answer here is B. Is everybody clear about this or not? So with this, let me take this opportunity to introduce, the shape of the crystals. These stones, the crystals which come in your urine when you do a complete urine examination will, and the shape of the crystal may give you an idea as to what is the chemical composition of the stone of the kidney. So the first is, what is this shape? Can anyone tell me? What is this shape? What is this shape? Anyone? So remember, this is your dumbbell bell shape. Let's get the shapes right. Then we will see which shape is for what. What is this shape? Something like this. What is this shape? So this is your envelope shape. Okay. What is this shape? This is rhomboid shape. The difference between rhomboid and a rectangle is in rhomboid rectangle all the angles are 90 degree. Here the angles are not 90 degree. Okay. So this is a rhomboid. What is this shape? Looking very similar to your envelope shape but different. So this is your coffin shaped crystals. What is this? Clearly you can see this is needle shaped, but you can also say that the ends are blunt end needle. Okay. And what is this shape? This is a hexagonal shaped crystals. So are you all clear with the kind with the shapes, which are very different shapes? Can we go and name these crystals based on the shape? What kind of shape? Is everybody clear? Any doubt in terms of shape? So remember one thing: when we are talking about dumbbell shape, this both dumbbell shaped and envelope shaped are calcium oxalate crystals. Calcium oxalate crystals. This is calcium oxalate monohydrate crystals, and this is calcium oxalate dihydrate crystal. Which monohydrate means one molecule of water, dihydrate means two molecules of water. So both of these are calcium oxalate. Remember, calcium oxalate is the most common type of stones. Most common type of renal stone is your calcium oxalate stones. Is everybody clear? What is this rhomboid shaped crystals? Anyone? What is this rhomboid shaped crystal? In comment, can anyone write me what is the rhomboid shaped crystals? Anyone? So we're talking about uric acid crystals. Okay? Uric acid crystals are your rhomboid shaped crystals. What is this coffin shaped crystals? Coffin shaped crystals, anyone? So it is triple phosphate. Why triple phosphate? So calcium, magnesium, and ammonium phosphate. So three molecules phosphate. So that is why it is called as triple phosphate. So it is envelope shape. Sorry, it is coffin shape. Very similar to. So this is your envelope shape, and this is your coffin shape. Okay, everybody clear? What is this blunt end needles? Remember, this is calcium phosphate crystals, and lastly hexagon. This is cystine crystals. Is everybody clear about the shape of the crystals? Is everybody clear about the shape of the crystals? Okay. So renal stones being very critical. Let me take to you about some of the common renal stones and their characteristic features, because again renal stone is very important topic. So let's talk first about the most common renal stone. So most common renal stone. Write in the comment what is the most common renal stone. Anyone? What is the most common renal stone? Basically, it is calcium oxalate. And as I have told you, it exists in two form: monohydrate form and dihydrate form. And we already have seen monohydrate is dumbbell shaped crystals, and dihydrate is your envelope shaped crystals. Okay, and these are all. So few other important points. So for every stone, there are certain things which you have to remember. So you have to know the shape of the crystals for every stone. You also have to know if the stone is found in certain pH. Some stones form in acidic pH, some stone forms in the basic pH. So is there some correlation of the formation of the stone with the pH of the urine? So that is what for everyone. Then also you may have to know that what are the causes of the those particular stone. And lastly, how to prevent reoccurrence. Look, stone has formed. If it is small, we will go for it will and if it is big, we will go for surgical intervention. But the major point about every stone is how do we prevent reoccurrence. So these are the things which you have to remember. So most common renal stone: calcium oxalate stone, monohydrate, dihydrate form, dumbbell bale shape, envelope shape. The shapes I have already formed. So two more things. So remember, all these are radio opaque stone. Calcium is there, so it will be radio opaque. Most important, this is pH independent. So many of you might be giving citralica to your patients who is having recurrent UTI or all. So in stones, because this is pH independent, so acidification or alkalization will not dissolve these stones. So this is a very critical part. Okay. So this is about calcium oxalate. Let's talk about another calcium stone, that is calcium phosphate stones. Okay. So calcium phosphate stones are formed. So first of all, what is the shape? We have just seen these are needle shaped crystals. These are needle shaped crystals. Okay. Now they are formed either when calcium is increased or even when phosphate is increased. Very important. It is the precipitation of calcium phosphate can happen when the calcium is high or even when the phosphate is high. This is a very important. Calcium high. What condition do we see? Can anyone can tell me? In what condition we see calcium as high? It is very good. Hyperthyroidism. Okay. Hyperthyroidism. And what condition phosphate is high? Okay, that is hypoparathyroidism. Okay. So in both these conditions we are going to see calcium phosphate stones. Okay, these are rosette crystals, also called as blunted needles crystals. Let's look at another very important stones from exam point of view, and these are called as triple phosphate or struvite or staghorn calculus. Okay. Now let's understand all these words and names. So why it is called as triple phosphate? Anyone? Can anyone tell me why it is called as triple phosphate? So here the chemical composition is calcium, magnesium, ammonium, phosphate. So that is why it is called as triple phosphate stones. Why staghorn calculus? These are very slow growing stones, but eventually they will grow very large in size and they will almost grow the entire into the entire papilla, pushing the renal, suppressing the renal uh, parenchyma. So that is why they are called as staghorn. Okay, staghorn caliculi. Like a staghorn, it will be there. The appearance will be like of a staghorn. Now, obviously, because calcium is there, will it be radio opaque, radiolucent? So this will be radio opaque. Okay. Now, the most interesting part about this particular stone is ammonium. So this stone is found when there is a urinary infection with any organism that will produce urease. So what is going to happen? Urea is there in our urine. So if any organism produces urease, what it will this do? It will break down this urea into ammonium. And remember, this ammonium is alkaline, and this ammonium will crystallize and form stones. So first of all, it is seen in alkaline urine. So in these cases, acidification of urine will lead to dissolution of this stone. And lastly, what are these urease producing organisms? So very important is protease infection. So protease mirabilis infection or protease infection is because it will produce urease, it will convert urea into ammonium, which is alkaline, then it will crystallize. Is everybody clear? And we have already seen it gives a coffin lid appearance. Any doubt till now? Let's look at the next category of stone, that is uric acid stones. So acid stones are the softest stones. So they are very soft stones. Okay, they occur in because it is an acid. All of you can very easily see it's an acid. So they are found in the acidic urine. We have already seen they are radiolucent. Only two stones are radiolucent: uric acid and xanthine. Okay, and you know, so this is about uric acid stones, and obviously because there is either an increased synthesis of uric acid or increased excretion of uric acid, based on that whatever treatment you may be giving. So this is, there are two other stones not very commonly asked but you have to know from exam point of view. One is cystine stones. Okay, normally not seen, but in patients who have a defective dibasic, which means two amino acid, dibasic amino acid transporter. In the renal tissue, there is a defective dibasic amino acid transporter, and because of that, CoLA, that is cysteine, ornithine, alanine, sorry, lysine, these are all basic amino acid, and arginine. All these four amino acids are coming in the urine. Okay? These stones are hexagonal, found in acidic urine. Okay, and and more important, these are the hardest stones. So whenever in a question they mention about cysteine stone, even if the size is small, you will never use extracorporeal shockwave therapy, lithotripsy, to break these stones because they are very hard stones. Is everybody clear? What is the management? How do we treat it? So we treat it with D penicillamine. Another drug which we are using is tiopronin, tiopronin. Okay, and all of these increases the solubility of cysteine. The last stone is xanthine. Okay, the defective enzyme is xanthine oxidase. It is irregular in shape, and also it is radiolucent. Is radiolucent. Again, the treatment is something very similar to what we use for cysteine stones. So this is all about renal stones, and this was super important topic. That's why I have taken it in so detail. And when we talk about radiolucent stones, uric acid is the. Is everybody clear about this particular topic? Is everybody clear about this particular topic? Excellent. Let's look at the next question for today. Muscles cannot participate in the gluconeogenesis because of absence of, okay, glucokinase, glucose 6 phosphatase, muscle phosphorylase, or phosphoglucomutase. So, if you know the answer, if you know the correct answer, write in the comment below. Write in the comment if you know the correct answer. That why is muscle not able to produce or participate in gluconeogenesis. Now, first of all, very important, whenever you are given an enzyme, you should know its function. Okay, then only you will be. So, what is the function of glucokinase? So, any kinase means they will add phosphate. Here, this glucokinase is adding phosphate to glucose. So, glucose to glucose 6 phosphate. Okay, for that matter, even hexokinase will convert glucose to glucose 6 phosphate because kinase means addition of phosphate and glucose means glucose. Any doubt? Let's look at this glucose 6 phosphatase. What does phosphatase do? Anyone? What does phosphatase do? So, phosphatase will remove phosphate. Okay, so it will do the opposite. So, it will convert glucose 6 phosphate to glucose. Any doubt? What is muscle phosphorylase? Okay, muscle phosphorylase, it will remove phosphate and lead to the formation of, it will be cutting the glycogen molecules, okay, in the muscle. And phosphoglucomutase, so mutase means isomerization. Okay, so phosphoglucomutase will convert glucose 6 phosphate, okay, into glucose 1 phosphate into glucose 6 phosphate, or vice versa. So that is the function of phosphoglucomutase. Now, we know the last step of gluconeogenesis involves conversion of glucose 6 phosphate to glucose, isn't it? And because specifically we talk muscle lacks this enzyme, that is why it is not able to convert the glucose 6 phosphate into glucose, and so not able to participate in the gluconeogenesis. Now, very important, and another set of information related to this is glycogen and muscle and liver glycogen. So muscle and liver both have glycogen, right? Both have glycogen. However, there is some very subtle differences between the glycogen which is stored in the liver and the glycogen which is stored in the muscle. and that you have to know from for exam point of view. Number first is, let's talk about the amount. So remember, liver has higher density of glycogen storage, okay, whereas muscle has overall total higher amount of glycogen, because muscle mass is less even though density is less. So density of glycogen storage is less in the muscle, but because muscle mass is more, so overall quantity of glycogen is higher in muscle, and this is what they are going to trick you in the exam. Okay, so density of glycogen storage is higher in liver. However, the total amount of glycogen storage, if they ask you, don't answer liver, answer is at muscle. Now let's look at the property. Now when we talk about liver, liver is like mother. Whatever glycogen it has, it will completely break down into glucose. This glucose will go into circulation and will be available for the entire body. Muscle is very, very selfish. So it breaks glycogen only till glucose 6 phosphate, because I've told you just the glucose 6 phosphate cannot be converted to glucose in muscle because it lacks, you know, glycogen phosphorylase. It does not have phosphorylase. Okay, it does not have phosphatase. Glucose 6 phosphatase is not there. Okay, so this can only be utilized or is available only for the muscle cell. This is the second difference. The third difference being that in liver the amount of glycogen keeps on varying. It will keep increasing and decreasing with. And when we talk about the increase, when is the increase happening? Increase is related to the fed state. Fed state. Whenever the body is in the fed state, the amount of glycogen in the liver will be increased. And what is the decrease associated with? What is the decrease associated with? Decrease is associated with fasting state. Decrease is associated with fasting state. Decrease is associated with fasting state. So in liver, the glycogen level keeps on coming down and up and down and up, but the up and down is related to the fed and the fasting state. In muscle also, the amount of glycogen keeps on varying up and down, up and down, up and down. But here it is not related to the fed and fasting state. So it increases in the rest state. Whenever the muscle is resting, the amount of glycogen will increase and it decreases. So it decreases in fasting state. Is this clear? In fasting state, in sorry, exercising state. Exercising state. So whenever the muscle is exercising, its glycogen will come down. Whenever the muscle is in a fed, the body is in a fed state, the amount of glycogen in the muscle will. So these are the three very, very critical differences between glycogen of liver and muscle, very frequently asked in your examination. Is everybody clear? So, just a reminder about our daily WhatsApp update. You know that I send daily updates, in terms of concept card, short videos, quizzes, master classes, even live session notifications, a lot of free PDFs which we create, mini courses which we create, and all these you can get it for free if you join our groups. Now, these groups are admin post group only, which means no good morning, no good evening messages, no funny jokes being forwarded, only high quality content on your WhatsApp. So, and whenever, because we post you in WhatsApp group, you can have a look at it as per your time. Okay, so these are very, very important groups, and the best part is if you are a first year student, you join the first year group and you will get update only regarding anatomy, physiology, biochemistry. If you are a second year student, you will get path, pharma, micro, forensic, as well as some anatomy, physiology, biochemistry update. So these groups have very, very specific updates as per your profile, and I'll definitely feel it will help you. And because these are WhatsApp group, if they do not benefit you, you can easily exit that group. But I know that hardly any student exit because they love the kind of updates which I send regularly. So just a small reminder that go to medicohubs.org/groups and join these groups. Let's look at this question. This is the next question. A 35-year-old lady presents in casualty with symptom of acute onset breathlessness, palpitation, sweating, and nausea. Okay? So this is a 35-year-old lady. Physical examination and workup were unremarkable. What which of the following best explains the episode? And your options are phobia, mania, generalized anxiety disorder, and panic attack. So what will be the correct answer? Anyone? Anyone in the comment? Can you all write in the comment what will be the correct answer according to you? What will be the correct answer according to anyone? So let's look at some of these. So phobia is generally related to some specific, cause or stimulus. Okay, maybe phobia to height or closed spaces. But here there is no specific cause. Is it clear? Mania is euphoria and restlessness. So mania is completely different. So we can easily rule it out. Now we have got generalized anxiety disorder and panic attack. Can anyone tell me, is it a generalized anxiety disorder or a panic attack? Anyone? Now, what is panic attack? Panic attack, let's write it. What is panic attack? So, it's basically an abrupt, intense fear or discomfort. The critical part is it does not start without any stressor. So, there is no stressor or no specific stressing element which will cause this panic attack. Okay, so and we have told you about a specific phobia or social phobia, or there is no specific cause. Okay, and when these symptoms are present for more than 1 month, so this is the first episode the patient is presenting. If the symptoms of recurrent panic attacks are present for more than one, then we call it as a panic disorder. Is everybody clear in this definition? Okay. So how do you define, or how do you make a diagnosis of panic attack? There are there are certain basically diagnostic features. So let's look at diagnostic features. What are the clinical features and how do we? So palpitation will be there, sweating, trembling, shortness of breath, choking sensation. So patient may talk about chest pain or discomfort, okay, nausea, lightheadedness, dizziness, okay, paresthesias. So all these symptoms, okay, they can also be fear of losing control or going crazy, or even fear of dying. So out of this, any four symptoms, if it is present without any cause being detected, then you mention it as panic attack. Then you mention it as panic attack. Is this clear, everybody? What is panic attack? Okay. And how do we manage it? Basically, immediately you can give some benzodiazepines. Okay. Or for long-term SSRIs have been found to be very, very helpful. Is everybody clear about this? Is everybody clear? Any doubt? Any questions? Okay. So this was today's sessions. I have tried to take three, four very, very critical or very important topics. This brings us to the end. I'm not going to take the last question. So, and let me talk about the challenge which most of my students face, and that is revision. Every student, when they do not qualify, and when I talk to them, they say that, sir, I have read the topic. Sir, I was knowing the questions, but I was not knowing. I was getting confused in the last two options, or I was not exactly able to find the answer, and all this is attributed to revision. Okay, some of them knew what is their problem, that they were not able to revise, and some of them did not know that why they are not able to get the questions correct in the examination. So revision was always a big challenge whenever I talk to my students over phone or over our mentorship sessions. And why revision is such a big challenge? Because when you talk about NEET PG or INI CET or NeXT PG, huge amount of information you have to remember. You know, there are 20 subjects. Each subject will have at least 50, 60 chapters, and each chapter will have 3 to 4 pages of notes. I mean, so much of information which you have to remember. Also, there's nothing exciting about revising. You know, in fact, it's very frustrating because you keep forgetting whatever you have learned. You keep forgetting it. So, and it's very frustrating. You've just learned something to yesterday. Even I will forget. You know, if I have read something today and if I revise it, once or twice or revise it after a long delay, then I'll forget it. So we keep forgetting, and that is why revision is a very very big challenge. And for that reason, what we have come up is something called as concept card. So how is concept card going to help you in revise? First of all, we have kept the information very very limited in our concept. Only high yield topic, high yield information is there in the concept card. All the information we have tried to convert it into either an image or a flow chart or in a very visually appealing way so that you just see that information, it gets printed in your examination. Okay, and we have converted all the information into active learning. For example, let's say there is a reaction of A converting into B. So you will not be given the entire reaction. You will be shown this question mark. It will think of the reactant, think of the cofactor, think of the results or the products. So that ways you are able to always think what is, it's more of an active revision, and that is concept card. How do you access concept card? You can go to Play Store, just download Medico Apps Concept Card. It is one of the first apps, and you can download it and use it for yourself. If you like this session, please give this video a thumbs up. Share this session with your friends so that more of the students can come aboard, and it's much fruitful discussion. Make sure you leave a comment in the comment section if you have any doubt or follow-up question on this particular session. If you are new, if this is your first time, then do hit the subscribe button and keep on your bell notifications so that you get a notification whenever I go live. One last reminder. So for this week, we planned 3 sessions. I've already taken 2 sessions. This is the third session tomorrow at exactly 4:30 p.m. So hope to see you then, and hope to see you tomorrow. And hope you have understood. So in today's sessions, what all we learned? In today's session, we started with renal stones. So a very very important exam important. Then we looked about a question on gluconeogenesis and glycogen, muscle and phosphate. Very important topic. And the third topic, what did we see? Third topic we studied was panic, panic attack, acute panic attack. So hope you really enjoyed the session. Thank you so much, guys, for being a part of this session. Thank you so much.